This is Dr. Anil Shah. I'm going to be talking about revision rhinoplasty. This is a spicy topic. So much goes into revision rhinoplasty where, again, lots of different things can happen. And I've changed my stance in revision rhinoplasty a little bit. The way that a lot of us think about revision rhinoplasty is this massive procedure where you're adding all this structure and all this support, which is all super important. But for me, it was kind of analyzing where a lot of patients, what they want and how to achieve it. So this really altered some of my techniques. And even from 15 years ago, and I wasn't able to do some of these things because I didn't invent them yet. Okay, so if this is a reminder, if you really want to just get to the details, the before and after, and the summary of this, go to the end of this video. But we're going to do kind of a deeper analysis of this patient and talk for a little while. So this is a patient. This is actually patient Elise. I have to be my patient care coordinator. We're looking at her nose. Before she started with me, she had her nose done elsewhere. And kind of common things that we can see. And these are common in revision rhinoplasty. The first issue that we're going to see is that her nose is overprojected. Very common to see this. Very hard to handle projection and overprojection in rhinoplasty. One of the most common things that we can see in rhinoplasty. You can see that it's overprojected because if we look at her chin, look at her lip, and look where the nose is at, it's sticking out farther than is ideal for her facial features. If we look at the rest of the nose as well, we're going to see there's almost like this little scoop for the nose where it doesn't quite balance out. We'll balance this out through here. We can see that. And that's kind of the classic stigmata of having had a chisel to the nose. And so I don't like hammers, don't like chisels. I don't know if they create beautiful noses. And if you think about it, if you really wanted to make something really refined, even in sculpture, you don't use a chisel. And again, there's hand rasp and other things, but I'm really a big fan of ultrasonic rhinoplasty. One of the bigger advances in rhinoplasty, and again, that technique that began in roughly 2015, 2016, 2017, and it really didn't reach worldwide acclaim until a few years later, and I've been a big fan of it. And have refined those techniques with ultrasonic rhinoplasty. So that trying to avoid that little bit of a bump there. She's also got some nostril alar retraction we can see through there. Another common stigmata of having had a rhinoplasty. I've written an article with Dr. Ashland Alexander and Dr. Minas Constantinides, and we talked about ways to manage alar retraction. And so that is something that's interesting as well. And that's very common to see that in rhinoplasty. And then the columella, this is that little portion of the nose. Sometimes we don't know this terminology, but we'll talk about it. Hanging columella after rhinoplasty, another one of the issues that we see commonly with rhinoplasties performed where patients aren't happy. And we're going to fast forward here. We can see with smiling, there's the nose. We can see the overprojection when we look at the nose and see how it moves in the 3/4 view. And if we pause here, we can see some issues with the nose. We can see the deviation. We can see the obvious indent from the chisel. We can see the fullness in the tip. We can see the asymmetry of the nose. We're going to look at some different camera angles in here. Fullness in the tip. Again, there's the columella that's too low. There's the tip that's fuller. There's that obvious chisel mark from the nose. A couple different perspectives on this nose before. We're going to look a little closer, more detail. Again, we can see the overprojection here. We can see how the super tip is still full. So even though this is kind of has a couple different things going on, we're trying to think of a smooth nose. And again, here we can see it goes in and out, and then in, and then out, and then it goes back out, and then in. So we want more of a smoother shape that balances out with the facial features. Again, gorgeous facial features through here. Again, not trying to be critical of her in any ways. It's just more about did she get the result that she wanted from that front view. We'll look through here again. We can see that deviation. We can see how the tip is fuller. Again, notice how the eyes don't stand out as much. Again, with the projection. So those are all kind of fun things to see in the nose. This is a look on the intraop table. So on the table, we want to make sure that the nose looks the way we want to. And so we know what we want to do with the nose. We talked about the deep projection part. But we can see how the columella is low. We can see the chisel mark from before. We can see the overprojection of the nose and the alar retraction. So we're going to have to talk about ways to remedy these things. As we look, we'll zoom in a little bit to see those details. We can see the chisel mark from before. Get an open rhino. Tip is fuller. There's that alar retraction. And things always look different on the table than they will after we're done. And again, you could talk about just building this straight, but I think it's going to make her nose look too big. It's going to kind of overpower her face. So we have to somehow create all these changes to the nose. On deviated noses, you'll see that you get two different profiles. Again, there's the alar retraction, there's the fullness in the tip, there's the chisel mark from the nose. And you can see the potential in her nose, but doesn't really realized with the previous surgery. This is on the Aura table. You can see the nose is off to the left. There's the fullness in the tip. It's not a straight nose. And so we're going to try to support that. And you can see these shadows where the nose is fuller, but also is pinched in. Again, here you can see, again, some of the things that we're talking about. You can see the chisel mark. You can see the point over here, and you can see the tip fullness. So this is what was done before. You can see all the scar from her previous surgery. And you can actually see kind of that step off of where the bone is at, where they attempted to do the previous osteotomies. Obviously, her nose wasn't straighter. You can see the chisel mark a little bit on the inside. And you can see it clear, obviously, intraop, but again, from that side of it, you can see how the tip didn't really have as much structure and support from that area. So what I'll try to do is I'll try to identify, aside from getting the patient's nose exposed, I'll try to identify the lateral components of the nose, where the piriform aperture is at. And that's going to be looking at the sides of the bone, seeing how wide her nose is. So we're suctioning through here. This is me actually making osteotomies with the piezo, so the universal cutter tip. So I'm going to be narrowing her nasal bones. And this is kind of cool. You can see how I'm going to be, under direct visualization, narrowing everything. And with suction and the piezo, we're going to work our way around here and really just kind of define the nasal bones. And this is using that combination of suction and the device. This is the ultrasonic device over here. You can see how our nasal bones weren't properly addressed before. There's a step off. So we're going to just make these nasal bones reshaped. Once I've reshaped them, the nose should look better on the table. And again, this isn't just a feel thing. Sometimes if you use osteotomies without external osteotomies, we're actually going to put a suture internally to stabilize the whole keystone area. If you love septal anatomy, this is a great shot. You can see her anatomy where there's a spur going off into her left airway. And I think you should expose the entire septum, even all the way into the floor of the nose, so you can create this super straight structure. You can see she's off to her right. That's how she looked in her pictures. You can see again how the septum is crooked through here. We're going to expose it on both the left and the right. You can see that curve through here. So again, straightening out this whole septum. You can see how the septum has that curve off to her right, even when we're pulling on the patient's left. There's the deviation. So when I straighten the septum out, I oftentimes will kind of look inside the nose. I'll use this ultrasonic device to remove any extra bony protrusions. And again, this is safer than using a chisel. A chisel, you can rip the mucosa, but here we can kind of remove those extra bony things fairly safely. They're opening the airway. And a great way of straightening, part of the fully straightening process of this. So you have to ignore the orientation, but after I've straightened out the entire septum, you can see how the septum looks straight on the table right there, how that's aligned in the middle. Okay, this is kind of fun. This is a patient after, and you can see that a lot of the things we talked about, we were able to address. On this view, as we're looking through this, we can see her bridge is smoother, and that's with ultrasonic reshaping. If you think about the concept of using, again, a chisel, it's really hard to make a smooth surface. Using a ultrasonic reshaper, you can really soften that, improve that. I like her tip projection here. I like her columella, so things look promising. And again, I didn't want to have so much super tip break like she did before, where there's just so much different things. And you can see that there's a lot less noise going on with the nose. It's smoother throughout, smoother through here. We'll play this. And as we look, sorry about that camera flare, we'll see there's some improvement overall. And again, because we deprojected her nose, she's not going to look quite as defined. But we know that the structure is good, so I'm not worried about that. And sometimes, again, you'll see these amazing intraop shots where the patient's nose looks super defined, but if you don't deproject the nose properly, I found that the patients aren't happy later on. Their noses still look too big. This is her left view. Again, I like the way that looks. Her columella looks better. Her tip position actually looks good. Her length looks good. Again, you can see some bruising. Obviously, been working her nose. It's a revision nose. And you can see some definition, but again, there is still some fullness there, which is okay because we've deprojected her nose quite a bit to make that new contour. I'm going to show this as well because a lot of people don't believe Elise has scars. She does have scars. You can see the stitches there. One of the most requested comments she gets is, how will my scars look? Obviously, everyone's scars are going to look different. You know, they're not going to be the same on every person, but on Elise, if you try to look up close, which every consult does, you can't see her scars. And that might be, some of that might be technique, and some of that might be Elise herself. I think she healed really well. And this is from the top of the table. Because I deprojected her, her nose is going to be a little more swollen. And again, you're going to see some discoloration, and that's the skin envelope. All of this has to redrape over the nose. So again, if I want her nose to look amazing on the OR table, I would project her even more. Patients whose noses are super projected, but she's going to look horrible afterwards because her noses are already too projected. So again, I'm okay with her not having a perfect view at this point because I know the structure is good and I know how much the skin envelope, based on just experience and doing it, how much I expect that to kind of contract and work around her nose. Another shot of Elise on the table. And again, you can see improvement throughout here, improvement in shape. And again, we're seeing a little bit of weird shadows, but again, I'm very confident in her structure. Okay, so normally we don't record our patients sleeping, but Elise wanted us to capture everything. This is her immediately after. And even though she's a revision, you're really not seeing a lot of pain, basically no pain.
I feel great. I can breathe. I think that's assistance.
And most of our patients, they used to wake up before I did this thing called the nerve block. They used to wake up with a lot of pain. But basically, she's putting her thumbs up. Do you have any pain, any discomfort? And this is just the first moment she woke up. Okay, so this is the 1 week video for Elise. And this is kind of fun to see because she definitely has a little bit of a bruise. You can see as she's looking through here, she's a little swollen. But not bad for 1 week. I think we do have a little wraparound video of her. So this is her 1 week view. Again, we can see already that difference in her profile, in her columella. So things look promising when you see this, especially in revisions. There's always lots of little details we're looking at. Improvement in her front view. I'm glad we chose the projection. And again, if you look at the nose, it looks like a slightly upturned, but not too bad. And that's where we wanted to kind of put everything through there. 1 week, you'll see a little bit more of that. From the front view, she's swollen. And again, these are pretty common things to see post-surgery, especially post-revision. And the more you deproject the nose, the more the nose goes back. The more the front view is going to take a little longer to heal. But for 1 week, again, I think most patients are going to be happy at around, with the revision around 3 months. Primary is around 1 week to 1 month. But again, you can see improvement through all of that. Sutures are out, and she's ready to actually see what's working for us during the week. Okay, so here's Elise after. And we can see with her nose is straight. Her tip is defined. Everything looks better through here. The shape of the nostrils is better. Actually, the nostril symmetry is better. I really like her profile. I like the way her tip, her lip, and her chin kind of balance out together. I like how her nose is really feminine and balances out. And again, I think that balancing act really is important. I think the straightening of her nose and the balancing with the piezo made a big difference, but there's obviously lots of other factors here. We'll look at her other side. And again, we're seeing the two sides which were before different, now the same. And again, if we're creating that, she has actually stunning structural features. And now with her nose, it's all balanced together. And so it makes a big difference in her front view, her side views. So I think overall, a big difference for her. So let's talk about the summary points for her. So for Elise, she had a lot of the stigmata of having had a revision rhinoplasty. Her columella was lower. She had the chisel mark from her nose. Her nose was deviated. Her tip was fuller. Her nostrils are at different levels. She wasn't able to breathe as well. Her nose was over projected. All these things together kind of made the nose not visually as appealing as possible. And it's pretty common that some patients will have a rhinoplasty where they might look worse afterwards. Now, a lot of patients might emotionally feel worse when they have their nose. It's pretty common for patients to have a really good result and have one or two little things they're not happy with, and they'll kind of say they'll discount the rest of the nose. And I don't think that was what's going on here with Elise. I think with her, there was a lot of things that were visual and obvious. But I understand that some patients may feel that way about their nose. Getting the nose perfect is impossible, but getting it perfect for the patient or as ideal as possible for the patient is the goal, but never possible. In her case, we didn't have to use ear and or rib. We were able to use their existing septum because the surgeon didn't touch the septum. The approach over here differs too from traditional revision rhinoplasty approaches. I think at least when she was talking to some other doctors before she worked here, they talked to her about maybe grabbing cartilage from another source, maybe grabbing rib, grabbing ear, adding to her bridge, filling in this area that was depressed, keeping her projection, maybe adding to her projection to define the tip. These are common concepts that people often talk about, and this often leads to step 2 in the rhinoplasty spiral. The rhinoplasty spiral is when patients start off with their nose, and they did a rhinoplasty. They didn't do a lot of research on their rhinoplasty. They go to a random surgeon who doesn't do lots of noses. They look at their nose, and they're not happy with their nose. And they go to a revision rock doctor. They do a lot of research, and now this doctor does something completely different. They do super invasive techniques to the patient. And then the next thing you know, the patient's not happy, and now they're in a bigger spiral. Now they're like, what do I do? And less doctors can operate on them, and it becomes more and more just time for the patient to recuperate. I didn't want to do that, and that's not necessarily my goal for revision, so I'm really minimally invasive when I'm dealing with revisions. So what I want to do is keep the nose as pure and think of it almost like a primary. We straightened out her septum in this case. We worked with her tip, deprojected her nose, reshaped her nasal bones under direct visualization, and then really kind of created, I think, a beautiful nose that really fit her face better. We also had I had an in-depth conversation with Elise about what we were talking about and helped try to balance it. It's strange in my consultation process, which is different for every person, but I'll come up with an image that I like and an idea that I like, and then I'll actually have the patients kind of tweak it. I made my version of my nose, and actually Elise liked my version, and she got nervous, and she wanted her nose to actually come out bigger and wanted her bridge to be extended. And then I talked to her about that, and I was like, you're not going to look good with a larger nose. So she wanted a nose that was larger. Then we talked about it and changed that. And so then we looked at it again, and she's like, yeah, this is what I truly want. So the challenges in revision rhinoplasty, it's going to be 5 of the things that we talk about in the 5D nose. It's going to be the overprojection, which was handled, the length, which was handled for Elise, the hump, which was handled for Elise, the deviation, which was handled, and the tip. All of those are the 5 most common requested things, and that's why they're all kind of thinking. They're all really hard to do independently. To do them all together is, I think, pretty amazing. For her columella, this lower part, super common to see that and supporting that. And I think the other part that we don't talk about enough is the function. And for Elise coming in, she thought her breathing was okay, but afterwards somehow her breathing is better. So it's pretty common to see our patients actually improve their breathing scores. These scores are called NOSE scores, N-O-S-E scores, which we'll get their score beforehand, we'll get their score afterwards, and see what that number's at. So revision rhinoplasty, super challenging. There's lots of ways of doing it, but I think the traditional way of doing it, I guess traditional being from 2005, 10, 11, 12, where you take apart the whole nose, restructure everything, support it so that even if you sniff a little bit or super much, your nose doesn't move at all, but it's just really big and blocky. I don't know if my patients truly want that, because that's what their noses never look like. I think by supportive, thinking of a revision rhinoplasty like a primary rhinoplasty, trying to make as much natural things, and having patients have a realistic concept of what they want. There's a lot of dissatisfaction with rhinoplasty in general with patients, and it can be, again, an emotional target for them where they can look at something. It's very common for lots of patients also to look at one aspect of their nose and say, my nose is a failure because I have this or I have that. And there's some surgeons who will feed into this belief as well. But I think for all patients who are thinking of getting revision rhinoplasty, if you're mostly happy with your nose, I'll tell them don't touch it. Why change it? You have to wait. It's super technical and difficult. If you're super unhappy with your nose, seek someone who has noses that can create noses that you like, and go in there with realistic expectations. If you expect a miracle and expect your nose to be absolutely perfect, you're going to go down a path that's not correctable. So make sure that you can look at your nose and say, hey, I'm going to be fine if I can change this part and this part. I can change this part and that part. But again, I know I won't be able to get my nose perfect. You'll be happy.